Ashwini, you can start.
You can start. Okay, sir. So, good morning, everyone. So, today's topic is the basic hemodynamic interpretation. So, the cardiac physiology is described by considering heart and the arterial system. And the determinant of cardiac function are venous return, preload, afterload, and the properties of arterial system. That is the resistance and the compliance. So, this is the diagram which is explaining which is explaining the about the venous return. So basically, there is an equilibrium between the cardiac output and the venous return. So the venous return is basically determined by the right atrial pressure, mean systemic filling pressure, and the venous, and it is mainly determined by the difference between these two, and also upon the resistance of the venous return. So the veins and the venules represents the blood bulk of the large size and the high compliance. The volume that stretches the elastic vein provides the potential energy that generates the flow. So vein have the resting volume which does not stress their elastic wall and creates no pressure. This volume, which does not contribute to the venous flow, is called unstressed blood volume. And the amount of the blood added to the venous reservoir, which produces the tension in its wall and increase in the intravascular pressure, this part of the venous blood is called as stress blood volume. So the venous system is the large in adult women, and it contains approximately 70% of the total blood volume, that is 3.5 liters. So the venous compliance is 40 times greater than the arterial compliance. Under normal condition, the unstressed blood volume is approximately 70% of total blood volume. And if you are adding any alpha adrenergic mediated vasoconstriction, constrictors like NORAD, then the unstressed blood volume is moved to the stress blood volume. This concept we'll understand later in the upcoming slides. So the factors determining venous return are uh, the so just so the factors determining venous return are the mean filling pressure. We'll see the factors which determines venous return, and it is a mean circulatory filling pressure. The main determinant of the venous return is the mean circulatory filling pressure, which is the pressure within the circulating system when the heart and therefore circulation are stopped. The mean circulatory filling pressure is generated by the elastic recoil of whole cardiovascular system. The two factors that can modify mean circulatory filling pressure is volume of the blood in venous reservoir, which is increased by fluid administration, and the second is the capacitance of the venous system, which is under control of adrenergic flow. So the right atrial pressure is mainly influenced by the efficiency of cardiac pump. So the more efficient pump, lower is the right atrial pressure. Also, the right atrial pressure is affected by changes in the pleural pressure during ventilation, which contributes to the respiratory variation of the stroke volume. The resistance to the venous return is mainly influenced by the vein diameter. So the venous return curve. So the venous return is the blood flow crossing both vena cava, and it is determined by the resistance to the venous return and by the pressure gradient between the downstream pressure, that is right atrial pressure and mean circulatory filling pressure. So the venous return can be described as mean circulatory filling pressure minus right atrial pressure divided by the resistance to the venous return. So we can understand this in this way. When right atrial pressure is decreased, then there is a more pressure gradient between the right atrial pressure and the mean circulatory filling pressure. And because of this gradient, the venous return will increase. And when right atrial pressure is decreased, that is, then there won't be any gradient. So there won't be any flow. And if it is decreasing below the critical value, then venous return does not increase anymore. So this is called as flow limitation phenomenon when vein collapse as their intraluminal pressure becomes lower than the extraluminal pressure. So the Frank-Starling law is like cardiovascular system is the closed loop, and at equilibrium, the venous return equals to the cardiac output. So the relationship between the venous return and the cardiac output is basically explained by the Frank-Starling. Any increase in the ventricular preload increases the degree of the interaction between actin and myosin filament, which increases the intrinsic cardiac contractility and the stroke volume. When myofilaments are stretched at their maximum length, any increase in the cardiac preload does not increase the stroke volume anymore, and the ventricle becomes preload unresponsive. So as we can see in this diagram, the A part, the preload, this diagram is explaining the Frank-Starling law. So when we are giving the fluid to the patient and the venous return is equal to the cardiac output. So part A is showing that the response of the patient in the fluid responsive patient. And the part B is not associated, the fluid we are administering is the part B is not associated with a significant increase in the stroke volume, and this will happen in the fluid unresponsive patient. So the clinical application of this in the critically ill patient, the fluid administration increases the stress volume and the mean circulatory filling pressure. And the patient with or without fluid responsive behave differently. And in case of the fluid responsiveness, the fluid bolus increases the mean circulatory filling to some extent. And the gradient between the mean circulatory filling pressure and the right atrial pressure increases, and the venous return increases, and so the cardiac output will also increase. So in case of the fluid unresponsive patient, the volume expansion increases the mean circulatory pressure to some extent. The increase in the preload is not transferred to the increase in the stroke volume. The end-diastolic, so what will happen? The end-diastolic ventricular pressure will increase, which lead to the increase in the right atrial pressure. As a result, there won't be any gradient formation between the mean circulatory filling pressure and the right atrial pressure, which results in the no increase in the cardiac output and no increase in the venous return, and the cardiac output won't be increased. So the another use is in the septic shock. So when norepinephrine is usually administered with the aim of increasing arterial tone and mean arterial pressure, it has a significant venous effect also. So as I have explained before, if we are administering any alpha adrenergic agonist, then it is causing the recruitment of the unstressed volume. The same thing is happening when we are administering norepinephrine. So because of the administration of this norepinephrine, there will be the recruitment of this unstressed volume, which is equivalent to the volume expansion of the 1 liter. So if we are giving norepinephrine to the patient, then it will increase basically its preload, which will increase in the cardiac output. But this will happen only in the preload responsive patient. So the increase in the preload due to recruitment of the unstressed volume through vasoconstriction results into the venous capacity. So the both norepinephrine and the fluid contribute to the increase into the mean circulatory filling pressure. So once norepinephrine has been started or increased, any additional fluid infusion may increase mean circulatory filling pressure to large extent than before. So the fluid induced increase in the stress volume occurs when the fluid is administered in constricted venous network rather than in the large and the dilated venous tract. So the early administration of the norepinephrine along with the fluid during septic shock resuscitation, especially in patients with the severe hypotension. Not only is the norepinephrine restoring arterial pressure rapidly, but also it potentiates the effect of the fluid administration. So this is the paper which is published in the BMC Journal, which shows the effect of the very early start of norepinephrine in patient with the septic shock. And according to this study, if we are giving vasopressors at the initial stage, that was associated with the lower amount of the resuscitation fluid, less fluid accumulation, and shortening of the hypotension times. So the very early start of vasopressor, even before completing predefined volume of the fluid resuscitation, seems to be safe intervention with potential beneficial effect in the clinical outcome. So by now we understand, so it's very important to know the which patient are fluid responsive and which are not. Because if we are giving the fluid, if we are giving fluid to the patient who is not fluid responsive, then it will cause the fluid accumulation, and it will cause the increase in the mortality. So there are parameters which for determining the fluid responsiveness, like passive leg raising, pulse pressure variation, stroke volume variation, tidal volume challenge, and the echocardiographic variance. We'll see all these parameters one by one. So the passive leg raising test, it is performed by transferring patient from semi-recumbent position to the position where trunk is horizontal and the lower limbs are elevated at 30 to 45 degrees. So it causes the mobilization of blood from the splanchnic territory and the lower limb and significantly increases the mean systemic pressure, the upstream pressure of the systemic venous system. So the passive leg raising test increases the cardiac preload and allows the assessment of the preload responsiveness of both ventricles. After performing this passive leg raising test, there is a self-transfusion of approximately 300 ml of the blood. And the response of the passive leg raising test can be assessed by velocity time integral of left ventricular outflow tract obtained by echocardiography, measured before and after PLR test. Another non-invasive method to measure the response to the PLR is measurement of ATCO2 variation. So the advantage of this test is reversible. So no fluid infusion is required. It works regardless of breathing activity, cardiac rhythm, lung compliance, and tidal volume. The limitations are it requires the direct estimation of cardiac output and stroke volume, and it comes false negative in case of intra-abdominal hypertension. So the another variable is pulse pressure variation and stroke volume variation. So these indices are derived from the waveform analysis and are most commonly used in indices in the ICU. The pulse pressure variation is the difference between maximum and minimum pulse pressure value over one ventilatory cycle divided by average value of these two. So stroke volume variation is derived by the analysis of arterial pressure waveform. The cardiac output monitoring using the calibrated and uncalibrated pulse counter analysis automatically calculate these parameters. In preload responsive patient, the pulse pressure variation and stroke volume variation are high, and low values are associated with preload unresponsiveness. The threshold for fluid responsiveness for pulse pressure variation and stroke volume variation is more than 15%. So pulse pressure variation and stroke volume variation are limited by the fact that they cannot be used in many clinical conditions, like low heart rate, respiratory rate ratio, low respiratory rate ratio, which creates some false negative. If there are irregular heartbeats, arrhythmias, then it will result into the false positive test. Mechanical ventilation with low tidal volume, which will lead to the false negative test. And if there is an increase in intra-abdominal pressure, then will get false positive results. The next variable is the tidal volume challenge. The dynamic indices of pulse pressure variation and stroke volume variation are not reliable in predicting fluid responsiveness during low tidal volume ventilation. That is, tidal volume is less than 6 ml per kg of predicted body weight. So pulse pressure variation is the reliable predictor of the fluid responsiveness only when tidal volume is at least 8 ml per kg of predicted body weight. So the low tidal volume might not be sufficient to produce significant change in intrathoracic pressure, making these indices indicate non-responsive state even in non-response. So this may limit the use of pulse pressure variation and stroke volume variation in low tidal volume. To overcome this, the tidal volume challenge has been introduced. The test involves transiently increasing tidal volume from 6 ml per kg of predicted body weight to 8 ml per kg for 1 minute in paralyzed patient and observing the change in pulse pressure variation and stroke volume variation from baseline to that of the 8 ml per kg of body. A change in pulse pressure variation of 3.5% or stroke volume variation of 2.5% after performing tidal volume challenge reliably predict fluid responsiveness. Now the next is echocardiographic variable, which is left ventricular end-diastolic volume. So the left ventricular end-diastolic volume is directly proportional to the left ventricular end-diastolic, and it is the indicator of preload. So the technique of measurement is the left ventricular end-diastolic area is measured at mid-papillary level in parasternal short axis view. And alternatively, parasternal long axis view and apical four-chamber view can be used for calculation of ventricular size. Now, the interpretation of the measurement, the normal range of left ventricular end-diastolic index is between 8 and 12 centimeters. The presence of kissing papillary sign in the parasternal short axis view generally indicates severe hypovolemia of less than 5.5 centimeters square. Significant hypovolemia is likely with less than 10 centimeters of square of left ventricular end-diastolic area index. And the patient with the left ventricular end-diastolic index of more than 20 are likely to have volume over. Now, the advantage, it is a direct volume estimate of preload, and it is not influenced by intrathoracic pressure or intra-abdominal pressure, where CVP and IVC are not. So the limitations are, it needs good acoustic window is required for assessment. There can be individual variation in the calculation of it. The left ventricular end-diastolic area can be unreliable in patients with severe concentric left ventricular hypertrophy, as they can have low left ventricular end-diastolic area in the absence of hypovolemia. Left ventricular end-diastolic area is the static marker of the preload. The left ventricular end-diastolic area has failed to predict the fluid responsiveness. So the left ventricular end-diastolic area is not reliable indicator of fluid responsiveness in the patient. So next is the global end-diastolic volume. So besides cardiac output, transpulmonary thermodilution estimates several intrathoracic volume. So according to the Newman principle, the largest distribution of volume, the cold indicator between injection and the detection site. The total pulmonary volume is obtained by multiplying downslope time of thermodilution curve. Then subtracting pulmonary thermal volume from intrathoracic thermal volume estimates the global end-diastolic. The global end-diastolic volume index for a body surface is the volume of 4 cardiac chamber at end diastole. So the global end-diastolic volume is the larger than actual volume of 4 cardiac chamber because it includes the cardiac volume, part of superior vena cava, and the volume of aorta that are between bolus injection site and the thermistor. When cold boluses are injected through femoral venous catheter, normal value of the global end-diastolic volume is higher since it includes the volume of inferior vena. Now, the clinical use, it is a static marker of cardiac preload. In particular, global end-diastolic volume reliably tracks the changes in the preload induced by the volume expansion. Assessing the cardiac preload by the global end-diastolic volume may also help in determining shock origin where it is unclear. Now, the limitations are it cannot really differentiate between the right and left cardiac preload. It includes the volume of 4 cardiac cavities, so it overestimates the left ventricular preload in case of right ventricular dilation. Now we'll understand what is afterload. So afterload, it is a tension that needs to be generated into the ventricular wall in order to eject the blood into the arterial system during systole. Now there are many variables of the afterload, like systemic vascular resistance. The peripheral vascular resistance is same as systemic vascular resistance, and it is a resistance in the circulatory system that is used to create blood pressure. The flow of the blood and is also a component of the cardiac function. When blood vessel constrict, this leads to the increase into the systemic vascular resistance. When blood dilates, this leads to the decrease in systemic vascular resistance. So the vascular resistance is used to maintain organ perfusion. So the afterload is largely determined by resistance of the arterial system and the systemic vascular resistance. And it is calculated by mean arterial pressure minus central venous pressure divided by cardiac output into 80. Now the factors which directly decrease and increase SVR. So decrease SVR caused by anemia, sepsis, fever, anaphylaxis, general anesthetic agent. Increase SVR is caused by preeclampsia, hypertension, those who are smokers, diabetes, and obesity. So SVR is maybe indexed to the body surface area by substituting cardiac output in the equation for cardiac index. And the normal range is 1970 to 2309. The cardiac output, the next is cardiac output. The cardiac output is the amount of the blood the heart pumps from each ventricle per minute. It is usually expressed in the liter per minute. So the cardiac output is determined by heart rate into stroke. It depends on the preload, afterload, and contractility. So the normal values for resting healthy individuals would be approximately 5 liter to 8 liter. Now the stroke volume is the volume of blood in millimeter ejected from the each ventricle due to contraction of the heart muscle, which compress this ventricle. The stroke volume is the difference between the end-diastolic volume and the systolic volume. So the multiple factors affect the stroke volume. For example, factor that change in either end-diastolic volume or end-systolic volume will change the stroke volume. The three primary factors that regulate the stroke volume are preload, afterload, and contractility. The normal values for resting healthy individuals would be approximately 60 to 100. Now the equation, now the next is cardiac index. The equation for cardiac index is below the unit of liters per minute. The cardiac index is cardiac output upon body surface area. Now the clinical application of this is to differentiate between the various type of the shock. Like in cardiogenic shock, the systemic vascular resistance will increase, cardiac index will decrease, and the cardiac output will also decrease. In distributive shock, systemic vascular resistance will decrease, cardiac index will increase, and the cardiac output will increase. In hypovolumic shock, the systemic vascular resistance will increase, the cardiac index will decrease, and the cardiac output will also decrease. And in obstructive shock, systemic vascular resistance will be normal, cardiac index will decrease, and the cardiac output will decrease. Now, the next concept is the ventricular-arterial coupling. The dynamic interaction between the heart and the systemic circulation allows the cardiovascular system to be efficient in providing adequate cardiac output and the arterial pressure necessary for sufficient organ perfusion. When heart and the peripheral vascular system are coupled, then both cardiovascular performance and its associated cardiac energetics are optimal. So VA coupling is the effective index of mechanical performance of left ventricle and dynamic modulation, the cardiovascular system. The VA coupling can be defined as the ratio of arterial elastance to the ventricular elastance. So the ratio of the arterial elastance to the ventricular elastance has been demonstrated to be reliable and effective measure of the cardiovascular performance. So the left ventricular elastance, it is the load independent index of the myocardial contractility, LV inotropic efficiency. It should be considered as an integrated measure of the LV systolic performance derived from the complex association between inotropic efficiency and the functional, structural, and geometric characteristic of the left ventricle. The arterial elastance can be defined as the capability of the arterial vessel to increase the pressure when LV stroke volume increases. Now, how are we measuring this? So it is measured by non-invasive method with the help of echocardiography. And the formula for measuring left ventricular elastance is diastolic blood pressure minus end EST, that is estimated normalized ventricular elastance at the end and the onset of ejection, into systolic blood pressure into 0.9 by end EST into stroke volume, where stroke volume is a Doppler derived stroke volume. And the arterial elastance is calculated as end systolic pressure minus stroke volume. So it is a proportionate sum of heart rate and the arterial resistance, and ESP minus mu. So EA can be calculated as 0.9 into systolic arterial pressure upon stroke volume, where 0.9 is the systolic arterial pressure equals to the left ventricular end systolic pressure. Now, the clinical application of this is cardiovascular impairment leading to the acute hypotension and the stroke can occur. Shock can occur, and the cardiovascular dysfunction is generally characterized by altered EA by EAS due to either decrease in ventricular elastance or increase in the arterial elastance. The system becomes uncoupled when the ratio of arterial to the ventricular elastance is more than 1. So thank you.
Thank you, Ashwini, for taking us through the various hemodynamic parameters which are kind of give us a lot of value and information in the critically ill patients. See, many a times by the time the patient comes to the intensive care unit, you may not be having the required infrastructure to use advanced hemodynamics. So looking at the basic hemodynamic variables can give you a lot of information. For example, a patient has severe tachycardia or a very high heart rates. Now that will tell you a lot of things. Yes, apart from the inflammatory response, it can also tell you that the cardiovascular system is trying to compensate for a low cardiac output by increasing increasing the heart rate. Because we all know that the cardiac output is nothing but your heart rate into stroke volume. So if you have a patient with hypotension and tachycardia, then that indirectly tells you that the system is trying to compensate. Similarly, when you look at the systolic blood pressure or the diastolic blood pressure, or look at the pulse pressure. Now, if you have patients where your diastolic blood pressures are very to have advanced hemodynamic monitoring to measure the systemic vascular resistance. Usually, a very low diastolic blood pressure hints that you are dealing with a vasodilatory shock. And if you have patients who are prone for coronary artery disease, say you have an elderly patient who is a diabetic, hypertensive, or has a history of coronary artery disease, then when you see a blood pressure where the diastolic pressures are very low, you should be very careful because we know that the diastolic pressures are important for your coronary perfusion. So that should hint you to start your vasopressors early, hinting that you're probably dealing with a vasodilatory shock and get your diastolic pressures early. Similarly, when you see that the stroke volume or the pulse pressure the difference between the systolic and diastolic pressures is less, it will indirectly hint that the stroke volume is less. So merely looking at a lot of basic parameters, you can get significant information before even you start using your advanced hemodynamic variables. See, for a long time, when I was doing my post-graduation, we were all told to keep the CVP very high. I remember back in my anesthesia days, we were always told, get the CVP very high, CVP very high. But today we know now that when your CVP is very high, which is indirectly a reflection of your right atrial pressure, right? And we know that for venous return, you need the gradient between your mean systemic filling pressures and the right atrial pressures to be high. But if you have a high CVP or a high right atrial pressure, this gradient will be less. So even if you give fluids, your venous return does not actually increase. And hence your fluids may not result in increased cardiac output.
Yes.
Okay. So, very, very simple things at the bedside, right, can give you a lot of information about what is happening with your cardiovascular profile of the patient and probably hint you at what should be your initial interventions. Would you want to give fluids first? Do you want to give vasopressors first, etc., etc.? Okay.
Yes, sir.
Srinivas, do you want anything?
Yeah, I think it has been very extensively and very elegantly covered in a very crisp way. Only thing is, we should understand that there is no hemodynamic monitoring tool which is 100% effective in all situations. And always it is going to be an assessment of one marker, which is a marker of either volume or pressure, versus one that is reflecting the effect of this augmentation of volume or pressure on the peripheral oxygen delivery and extraction. So a combination of upstream and downstream markers are always going to be beneficial. The reason why no hemodynamic monitoring tool is absolutely foolproof and absolute indicator of volume status is the fact that we are only looking at one aspect of hemodynamic optimization, that is intravascular volume, and we are only looking at one aspect of hemodynamic result, that is pressure. So we are trying to increase the volume either in the systemic side or offload the pressure on the venous systemic side and increase the volume on the venous side, expecting a pressure to increase. Whereas there are other factors like the compliance of the chamber, compliance of the blood vessels, and their ability to contract and respond to the stretch that the volume is producing. Now, that aspect we have never been able to quantify consistently in terms of hemodynamics. Therefore, every tool will have its own policies. Every tool will have its drawbacks. We need to pick and choose the hemodynamic monitoring tool according to the clinical situation and the but importantly, as we understand hemodynamics more and more, we have now understood that simpler techniques and simpler measures are more often effective in troubleshooting and triaging your shock patients. Simplest being your pulse pressure and your diastolic pressure. When you have a situation where your pulse pressure is widened and your diastolic pressure is low, you are looking at a vasodilatory shock. If you're having a situation where there is a vasoconstriction, your diastolic pressures are low, are higher, and your pulse pressures are narrow. So basically, you can divide shock into wide pulse pressure, narrow pulse pressure, low diastolic pressure, high diastolic pressure, low cardiac output, cardiac output, and low SVR and high SVR. So this is a very simplistic way of looking at shock, but you need to pick and choose our understanding of hemodynamic tools. So it's an excellent presentation, Dr. Ashwini. Thank you very much.
Thank you, sir.
As she said during the course of the presentation, the heart and the lungs exist together, and what happens to the lungs will have an effect on the heart and vice versa. And that's what heart-lung interactions are all about. And you need to understand fluid responsiveness in the context of heart-lung interactions, ventricular interdependence, responsiveness of preload, and that we will deal with next week by Dr. Sudeshna. And please join us next week. In the meantime, have a safe and happy.
It's Dr. Arun.
Arun, okay. Dr. Arun, sorry, the change in the speaker. So Dr. Arun is going to do it. But in the meantime, please do have a safe, bright, and colorful Diwali. And we'll see you again next week on Tuesday morning at 8:50. Bye-bye.
Thank you, Ashwini.
Yes, sir. Thank you, sir. Thanks a lot, sir.